So the next is Associate Professor Dr. Wan Zamaniah, Betty Wan Ishak, or alias Wan Muhammad. She's a consultant clinical oncologist at the University of Malaya and also University of Malaya Specialist Center. I can say she's a hardcore of UM, graduated medical degree there for her postgraduate training and working there, and also involved with a master training program. She's a member of a lot of societies, both local and international, and her main interest in gastrointestinal cancer, head and neck cancer, gynecological cancer, breast cancer, and other solid tumors. And also principal investigator for several international trials, mainly GI tract and also head and neck cancer. So without further ado, we would like to invite Professor Dr. Wan Zamaniah, Wan Ishak, to deliver her lecture. So the floor is yours. Thank you.
Assalamualaikum and good afternoon. I'm Wan Zamaniah from Faculty of Medicine, University of Malaya. Thank you, Prof. Razif and the organizing committee for this invitation. My task today is to talk on the role of radiation therapy in the thyroid cancer management. So these are my disclosure. So these are the objectives for today's lecture. I'm going to talk on the thyroid cancer histology and prognosis, radiation therapy used in management of thyroid cancer, mainly radioactive iodine therapy as well as external beam radiotherapy, and then I'll move on to the conclusion. So moving on to the thyroid cancer histology, you can divide it into differentiated thyroid cancer that usually consists of papillary carcinoma and follicular carcinoma. And then we have medullary carcinoma, anaplastic carcinoma, and other type of cancers. Can be lymphoma, sarcoma, melanoma, and secondary tumors from the other sites. Today, I'm going to focus on the differentiated thyroid cancer treatment per se. So, who should treat thyroid cancer? Usually, the management of thyroid cancer should involve a multidisciplinary team, mainly thyroid or endocrine surgeon, radiologist, endocrinologist, nuclear physician, oncologist to decide on the need, timing, dosage, and duration of iodine remnant ablation or external beam radiotherapy. And then clinical geneticists, especially in the management of familial medullary thyroid cancer, and other support staff. For differentiated thyroid cancer, the overall prognosis is really good. More than 80% have excellent prognosis, with 20-year cause-specific mortality about less than 1%. But about 20% have poorer outcome, with multiple recurrences, distant metastasis, and death. And the 10-year mortality rate about 50 to 80%. For differentiated thyroid cancer, the prognostic factor depending on the age, low risk, age less than 55, higher mortality in age less than 10, higher recurrence and increased mortality in age more than 55. And for the tumor size, the bigger the tumor size, the worse the 20-year cancer-related mortality rate. As you can see that tumor size less than 4 cm, cancer mortality rate better at 6%, and tumor bigger than 7 cm, the cancer-related mortality rate about 50%. Soft tissue invasion also play important role. It increased the risk of death by 5 times. Distant metastasis also important, depending on the metastatic site. Brain median overall survival about 1 year, but for lung 10-year overall survival about 30 to 50% better than the brain. Histologic subtypes also important. Poor prognosis, for example, tau cell, insular, Hoffmann cell, Hertel cell, and etc. And molecular characteristic also play important role. Patient with BRAF mutation, telomerase reverse transcriptase mutation, and VEGF overexpression have a worse prognosis. This is the TNM staging according to AJCC 8th edition, and you can refer to this later. And this slide shows the prognostic stage group, which you can refer to it later as well. This slide shows you the ATA risk stratification system to estimate risk of persistent recurrent disease, and they stratify the risk into 3 criteria: low, intermediate, and high risk. Basically, the well-encapsulated, no lymph nodes involvement, no vascular invasion, no adverse variant histology, patient fall under low risk. For the intermediate risk, tumor more than 4 cm, with some adverse histology, some tissue invasion, and also maybe lymph nodes invasion fall under intermediate risk, but for the high risk, macroscopic tumor invasion seen, incomplete tumor resection seen, distant metastasis present, post-operative thyroglobulin level suggestive of distant metastasis, lymph nodes positive with largest dimension of more than 3 cm, and follicular thyroid cancer with extensive vascular variant falls under the high-risk category. Now I'll move on to the radiation therapy. In thyroid cancer, there are 2 types of radiation therapy that we normally use, mainly the radioactive iodine therapy, which is the unseen source used in the treatment of thyroid cancer, and as well as external beam radiation therapy. By definition, radiation therapy means the medical use of ionizing radiation as part of cancer treatment to control or kill malignant cells. It is a type of non-surgical treatment. Radioiodine therapy has been used in management of differentiated thyroid cancer since 1940s. Like iodine, radioiodine is taken up and concentrated in the thyroid follicular cells because they have membrane sodium iodide transporter. However, thyroid cancer cells have reduced expression of the transporter, which may account for the lower iodine 131 uptake in the thyroid cancer tissues. Iodine 131 cause acute thyroid cell death by emission of short path 1 to 2 millimeter beta particles. Cahill and colleagues did a long-term review on the outcomes following therapy in differentiated thyroid carcinoma anti-CTCS registry analysis from 1987 to 2012, looking at the effect of initial therapy on outcomes. And if you can see there, the effect of radioactive iodine for stage 3 and 4 is actually better compared to stage 1 and 2 in terms of overall survival. There are 3 systematic review and meta-analysis on the effectiveness of radioiodine in low-risk patients involving more than 1,000 papers. All these meta-analyses failed to find a benefit with regard to either overall recurrence rate or disease-specific mortality rate in low-risk tumors. So Sachs and colleagues has come up with this recommendation. For very low risk and low risk, we don't need to offer patients radioactive iodine. For moderate risk, certain criteria you can offer radioactive iodine therapy, and for the high risk, you need to offer patients with radioactive iodine therapy. ATA has come up with their own guideline based on the available data on who do we need to consider for radioactive iodine. For those with low risk, no strong data supporting iodine therapy, so we don't have to offer them radioiodine therapy. For those with intermediate risk, however, there are conflicting data, so we need to consider giving radioiodine to some appropriate cases, for example, tumor more than 4 cm with poor prognostic tumor variants with microscopic extra-thyroid extension and nearby structure invasion. And of course, for high-risk disease, advanced age, lymph nodes involvement, gross extra-thyroid extension with distant metastasis, they usually need radioactive iodine therapy. I think everybody know about the control of thyroid hormone pathway on the left panel that involve hypothalamus, anterior pituitary, and thyroid gland, and the synthesis of thyroid hormone and the role of iodine involvement in the thyroid hormone synthesis as shown on your right panel. Iodine 131 are the most favored radionuclide due to their beta and gamma ray emission and the half-life suitable for the therapy. Half-life being 8 days. Beta energy about 0.61 mega electron volt, and the gamma energy, as you can see, there's a range of 80 kilo electron volt, 284, 364, and 637 kilo electron volt. As mentioned before, thyroid tissue has unique ability to take up iodine from blood because they have membrane sodium iodide transporter. Normal thyroid cells, when present, will trap and organify the iodine 131 more than the thyroid cancer cells. And TSH will increase the uptake of radioiodine 131 into remnant thyroid tissue or differentiated thyroid cells, cancer cells, and increase the thyroglobulin synthesis and incorporation into the follicular cells. Therefore, before we put patient on, we give patient on radioiodine. The TSH level must be high, which is we aim for more than 30 nanogram per meal for good and effective radioiodine therapy. The recombinant human TSH act as the same manner as the endogenous TSH. Primary goals of radioactive iodine depending on the post-operative risk stratification of the individual patient. First one being remnant ablation to facilitate detection of recurrent disease and initial staging by tests such as TG measurement or whole body scan test. As adjuvant therapy intended to improve disease-free survival by theoretically destroying suspected but unproven residual disease, especially in patients at increased risk of disease recurrence, or as therapy intended to improve disease-specific and disease-free survival by treating the persistent disease at higher risk patients. Some additional consideration: patient comorbid, the type of tumors, as well as the surveillance procedures and patient preference. The advantages of ablation: if you achieve negative baseline scan following ablation, any subsequent uptake in the following whole body scan can reliably be interpreted as recurrence. And if you achieve undetectable thyroglobulin level post-ablation, any elevation later can be reliably be interpreted as recurrence. As normal thyroid tissue trap iodine more efficiently than tumor, its absence increases the efficacy of radioiodine therapy, and the detection and treatment of metastatic disease that may not be visible on whole body scan in the presence of normal thyroid tissue. So some principles of radioiodine therapy. The dose normally we give about 30 to 250 MCI according to local guidelines, depending on your treatment intent, either ablation, adjuvant, or treatment of metastatic disease. What we need to do, we need to withdraw tyrosine for at least 4 weeks before the treatment, and food containing iodine withdrawal 2 weeks prior to the radioiodine treatment. And if iodine-based contract imaging done prior, so we need to schedule the ablation for about 2 months post scan for optimal uptake. Post-therapy whole body scan usually done between 2 to 10 days after the treatment done. So these are the NCCN guidelines showing you the principles of radioiodine therapy administration. You can refer to this later. So high dose versus low dose, which one do we choose? Which one is better? There's a study by Schlusenberg and colleague which looking at the strategies of radioiodine ablation in patients with low-risk thyroid cancer, involving about 752 patients between year 2007 up to the year 2010, and 92% of these patients had papillary cancers. Two thyroid stimulating method using tyrosine hormone withdrawal and also recombinant human thyrotrophin therapy, and 2 radioiodine dose use, 1.1 gigabecquerel versus 3.7 gigabecquerel, which is 30 MCI versus 100 MCI in a 2x2 design. These are the patients and treatment characteristics in the study. In this study, they use ultrasound neck and thyroglobulin level measurement in the assessment. 95% have normal ultrasound neck, 95% have normal serum HTG of less than 1.0 nanogram per milliliter with undetectable NTTG. The thyroid ablation rate was completed in 92% of the patient, and the ablation rate was equivalent between iodine 131 doses of 30 versus 100 MCI, and between the two thyrotrophin stimulation method. So the conclusion being the use of recombinant human thyrotrophin and low iodine dose post-operative radioiodine ablation may be sufficient for the management of low-risk thyroid cancer. In the 5 years follow-up study, disease recurrence was not related to the strategies used for ablation. This data validate the use of 30 MCI radioactive iodine after human recombinant TSH for post-operative ablation in patients with low-risk thyroid cancer. There are two other studies with almost similar design using two thyroid-stimulating hormone method and two levels of radioiodine doses, which show that the two thyroid-stimulating hormone methods give similar outcomes, and the ablative effect of the two high-dose versus low-dose radioactive iodine also give similar outcomes. So in these slides, I just want to highlight that other than thyroid tissues, there are other normal physiological uptake areas, for example, in salivary gland, nasopharynx, bowel, stomach as well as bladder. Some special precaution following radioiodine therapy. For 24 hours after radioiodine therapy, drink plenty of fluid and empty bladder regularly. For 2 to 3 weeks after therapy, depending on the activity given, they need to carry treatment card with them all the time. Avoid contact with babies and pregnant ladies. They cannot breastfeed. Not to share bed with partners. Do not go to public areas. Do not travel by public transport if the journey lasts longer than 1 hour. Use their own cutlery and crockery separate from the rest of the family. They need to wash their clothes separately and flush twice toilets when they use it. For up to 6 months after treatment, they are not allowed to become pregnant. Some adverse effect of radioactive iodine, usually we divide it into acute and late effect. Swelling of salivary gland and discomfort, altered taste, reduced salivary flow, nausea, vomiting, transient bone marrow suppression in those with multiple bone mass, and reduced sperm count for the acute effect. And for the late effect, sialadenitis, xerostomia, lung fibrosis for those with widespread lung mets, leukemia, and bladder cancer. So we complete on the radioiodine therapy. Now I move on to external beam radiation therapy. So how does radiotherapy work? By direct effect and indirect effect. Direct effect, they hit the double-strand DNA directly and cause permanent damage for the body to repair. And indirect effect, by interaction with water, that actually produce free radicals, and these free radicals will damage the DNA, causing cell death. However, thyroid glands are not very radio sensitive for the external beam radiotherapy, as you can see on your screen. They are on the low sensitivity side. So we don't routinely give external beam radioiodine therapy to everybody except for this indication as palliation in patients with unresectable or locally advanced disease, or for symptomatic metastatic disease that is refractory to radioiodine. For inoperable macroscopic or microscopic residual disease after thyroidectomy or absent or inadequate iodine availability. For older patients more than 55 who T4 disease at the time of the surgery. Selected young patient with T4B or extensive T4A. Poor histology feature, insular polydifferentiated histologies who disease is resected, but in whom there's high risk, high likelihood of disease progression. Anaplastic medullary and polydifferentiated thyroid cancer. So the external beam radiotherapy volume, usually we target the thyroid bed or residual disease, draining lymph nodes, and usually we expand GTV, CTV about 0.5 to 1.5 centimeter, CTV to PTV 0.3 to 0.5 depending on the imaging type. The usual external beam radiotherapy dose, for radical dose for macroscopic disease 66 to 70 gray, microscopic disease 60 gray, and elective nodal dose 50 to 56 gray in 2 grays per fraction. For oligometastasis, usually we aim for cure and aim for high SBRT dose or high dose radiotherapy 40 to 60 gray in 2 gray per fraction. The palliative care dose usually 20 to 30 gray in 5 to 10 fraction. In treating thyroid cancer, you can deliver radiotherapy using 3 techniques, the IMRT, 3D conformal as well as 2D. What I'm showing you on the screen is actually using IMRT technique, whereby we treat the tumor in single phase, and you can shape the IMRT isodose according to the concavity of the neck as well as to minimize the dose to the spinal cord. In 3D conformal radiotherapy, usually you need to treat the patient in 2 phases to keep the cord at 46 Gray maximum, target volume being thyroid bed, lymph nodes level 2 to 5 as well as level 7. And phase 1 and phase 2 plan together to ensure spinal cord dose can be protectively calculated and altered if necessary. Total dose usually 60 Gray in 30 fraction. For the phase 2, off cord and deliver the remaining of the dose to the thyroid bed. In conclusion, thyroid cancers can be divided into 4 major groups: differentiated, medullary, anaplastic, and others. Prognosis depending on the age, histology, extent of the disease, metastatic site, and molecular characteristic. Surgery is the mainstay of the treatment. Based on the risk stratification post-surgery, radioactive iodine is usually indicated for selected intermediate risk and all high-risk cases. 30 MCI versus 100 MCI and human recombinant tyrosine stimulating hormone versus tyrosine withdrawal method are similar in results and outcome. External beam radiation therapy usually utilized in selected condition, non-operable, post-operative with involved margins, recurrence of non-radioiodine avid, high-risk histology with potentially non-radioiodine avid disease, and in palliative setting for tumor, bone mets, brain metastasis, and oligometastasis. With that, I end my presentation. Thank you very much.
Thank you very much to our speaker, Associate Professor Dr. Wan Zamaniah. So I think we can see in the Q&A section, there are some questions being asked to specific speakers. So I was waiting and see, I think there are no more questions. The questions the participants can view. Is there any question from panelists to your own colleagues here? Because I think if not, probably we should proceed to the next session, which is our case discussion. Prof. Dr. Wan, you have a question, or can we proceed?
Well, I can answer live. I don't think it's compulsory to do tracheostomy. Depends on the cases. If you think that the airway is compromised, then you need tracheostomy. But otherwise, you don't need tracheostomy. It's not compulsory, basically.
Okay, so there was a question answered there. Any more question that I missed?
Post-op gross macroscopic RF preferred or radiotherapy preferred? So in such case where you cannot do surgery anymore, if you want to give radiotherapy, RAI is the preferred option first, followed by radiotherapy. The reason being, we want to target those radioiodine avid cells rather than giving radiotherapy, because when we give radiotherapy, we are not sure whether the radiotherapy will convert all the cells into the non-radioiodine avid, which will defeat the purpose of the radioiodine therapy.
Okay, thank you. Any more questions? Anyone want to add on anything? No? Dr. Nani, are you ready for the case discussion? You are muted there.
Yep, I am.
Okay, so I will pass the next session to you, Dr. Nani. Thank you to all the speakers that has contributed to the session just now. Thank you.
Thank you. Thank you very much, Prof.